Hello and welcome to Module 2, Chapter 8. After making 30 critical planning decisions to ensure that the PLA-MNH group program is as effective as possible, this last decision isn't really a decision at all. It's a celebration. In this presentation, we will look into the future and calculate how many lives will be saved by the PLA-MNH group program. This will give something to come back to in the middle of the program when all the focus is on implementation, to provide a reminder about what all the hard work will achieve. This presentation is split into 5 sections. First, we will explore the key decision that needs to be made in relation to the program beneficiaries. Second, we will walk through the PLA-MNH group theory of change. This is important because it provides a basis for the next section, the recommendation to keep in mind when making decisions about the PLA-MNH group program beneficiaries. Then we will cover what to do next after reviewing this presentation. And finally, we will also give you guidance on how to get answers to any questions you might have. So let's look at the critical decision that needs to be made when projecting the PLA-MNH group program beneficiaries. We call this the PLA-MNH group program planning pyramid. This pyramid provides a snapshot of the key components of a PLA-MNH group program. These 8 components have been extensively researched and refined over the last 20 years. These experiences have helped to identify 31 key decisions across these components that need to be made when planning a PLA-MNH group program. Each decision is supported by a recommendation that has been extensively developed, tested, and refined in over 13 countries. Planning a PLA-MNH group program so that the components are aligned to these recommendations can maximize the chance of success, that the PLA-MNH group program enables mothers and newborns to survive and thrive. In this chapter, we will consider the beneficiaries of the PLA-MNH group program. To plan this component, one key decision needs to be made. Specifically, how many lives will the PLA-MNH group program save? But before we get to this, it will be helpful to walk through the PLA-MNH group theory of change. You may remember this diagram. It illustrates the PLA-MNH group causal mechanism. You may also remember that we slightly reorganized it in Chapter 6 to look like this. It is the same mechanism, but now better for our purposes in this chapter. This causal mechanism illustrates that certain practices can cause maternal and newborn health problems to arise. And these problems can have severe effects. They can kill, harm, or hold back women and newborns. They can prevent them from surviving and thriving. Luckily, there are a number of prevention and management behaviours that can prevent the maternal and newborn health problems from arising, or stop them from leading to their severe effects. Stop them from killing, harming, or holding back women and newborns. However, unfortunately, a range of socioeconomic barriers face women and newborns, which means they are not always able to choose to engage in these prevention and management behaviours. The good thing about this diagram is that it can easily be reorganised again to help explain the PLA-MNH group theory of change. Let's focus on effects first. They can stay here. Now let's reposition these behaviours here. Why? Because the prevention and management behaviours can stop the effects from happening. Now, what should we do with these barriers? Let's make them a bit smaller and move them here. This shows how the barriers can stop the prevention and management behaviours from being performed. There's more to add, so now let's shrink it all down a little like this and add the PLA-MNH groups and PLA-MNH group members. These come before the barriers because they can stop the barriers from having an effect. Now, if we add theory of change terminology, everything should become clear. For example, in theory of change terminology, the PLA-MNH groups are activities. Relevant indicators at this level of the theory of change could include things like the number of groups or the number of meetings. The PLA-MNH group members are what is called outputs. Our theory of change predicts that if PLA-MNH groups are formed, then people will join. Relevant indicators at this level of the theory of change include things like the number of pregnant women members, or the number of female members, number of adolescent members, or number of male members. The barriers are what is called proximal outcomes. Our theory of change predicts that if the PLA-MNH groups are implemented and people attend, then we will see changes in these barriers. For example, we'll see changes in knowledge, changes in attitudes and self-efficacy, changes in social support, and changes in the barriers experienced by women and newborns in accessing care and support. The prevention and management behaviours are what are called the distal outcomes. Once again, our theory of change predicts that if there are changes in the knowledge, attitudes, self-efficacy and social support, and barriers facing community members, then we will expect to see certain changes in behaviour. For example, changes in maternal and newborn care-seeking behaviours, such as uptake of antenatal care, skill delivery, and postnatal care. And also changes in home care behaviours, such as hygienic delivery practices, breastfeeding practices, and thermal care practices. Finally, the effects are what are called the impact. The final step of our theory of change predicts that if there are changes in the behaviours mentioned previously, then there will be a reduction in maternal and neonatal mortality. In the rest of this presentation, we will look specifically at how to calculate the projected impact of a PLA-MNH group program. How many lives will be saved? But it is also worth mentioning that this theory of change can guide two important PLA-MNH group program processes. First, the activities and outputs will be tracked on a monthly basis through the PLA-MNH group monitoring system. This allows for any problems to be identified and remedial actions quickly taken to ensure the PLA-MNH group program continues to trigger the rest of this theory of change at the outcome and impact levels. The PLA-MNH group program monitoring system is covered in more detail in modules 3, 4, 5, and 6 of this training course. And second, the outcomes and impacts will be assessed through the PLA-MNH group evaluation. PLA-MNH group program evaluation is covered in module 11 of this training course. However, this is a complex area. WCF are experts in the evaluation of PLA-MNH group programs, so please don't hesitate to get in touch through learn@womenandchildrenfirst.org.uk if you'd like further help with your evaluation plans. But now, let's return to the PLA-MNH group impact. Let's explore the recommendation in relation to Decision 31. How many lives will be saved by the PLA-MNH group program? Here, it might be worth recapping some of the information presented in Module 1, Chapter 3. The impact of the PLA-MNH group approach on maternal and newborn mortality has been evaluated through a cluster randomized control trial design, or RCT. RCTs are considered to be the most reliable form of scientific evidence in a hierarchy of evidence that influences healthcare policy and practice, because RCTs reduce spurious causality and bias. So how do they work? Well, in cluster RCTs, the population is split into equal-sized units, for example, villages, wards, or catchment areas. The clusters are then randomly split into two groups. This can be done simply by pulling them out of a hat or using a random number generator, but the result is the same. Allocation into the two groups is random. One group is then randomly chosen to receive the intervention, in this case, the PLA-MNH group approach, while the other group does not receive the intervention. It acts as a control. Then, after running the intervention for a period of time, the mortality rates are measured in both groups and compared. Because of random allocation, the differences in mortality rates between the two groups are attributable to the intervention under investigation, rather than any other factors. In total, between 1999 and 2011, 7 RCTs were conducted on PLA-MNH group programs in 4 countries, 1 in Nepal, 2 in India, 2 in Bangladesh, and 2 in Malawi. The results of all these RCTs were published. They showed a range in reduction of mortality, from maternal mortality between 9 and 80%, and for neonatal mortality between 10 and 41%. Subsequently, in 2013, a meta-analysis was undertaken. Data from all 7 RCTs was pooled. This provided a total trial population of over 2 million people. Within this population, over 120,000 births were recorded and followed up. The results were published in The Lancet. The meta-analysis found that where at least 30% of pregnant women were attending PLA-MNH groups, they succeeded in reducing maternal mortality by a phenomenal 49%. And it also found that where at least 30% of pregnant women were attending PLA-MNH groups, they succeeded in reducing neonatal mortality by an amazing 33%. In their Lancet paper, the authors concluded, with the participation of at least a third of pregnant women and adequate population coverage, women's groups practicing participatory learning and action are a cost-effective strategy to improve maternal and neonatal survival in low-resource settings. So, drawing on this evidence, the recommendation here states that where the PLA-MNH group program is delivered in line with the 30 PLA-MNH group planning recommendations, and particularly where it is delivered in rural areas, with one group per approximately 500 people, and at least 30% of pregnant women attending meetings, then it can reduce maternal mortality by up to 49% and neonatal mortality by up to 33%. The authors of the study previously mentioned also calculated the number of lives that could be saved globally if the PLA-MNH group approach could be scaled up. They concluded that if PLA-MNH groups could be scaled according to the 30 recommendations outlined already in this module, then they could save almost 60,000 maternal lives and over 400,000 newborn lives per year. However, even if not all the recommendations could be met, the authors assumed that the PLA-MNH groups could still save over 40,000 maternal and 250,000 newborn lives per year, as long as the key recommendations of rural, 500 people per group, and 30% of pregnant women attending are all met. To perform a similar calculation for this PLA-MNH group program, 5 key pieces of information will be required. First, the PLA-MNH group program population size. And second, the length of the PLA-MNH group program implementation phase. Data on the first will be available from Decision 2, which was covered in Chapter 4. Data on the second will be available from Decision 10, which was covered in Chapter 5. Third, the crude birth rate in the PLA-MNH group program area. Fourth, the baseline maternal mortality ratio in the PLA-MNH group program area. And fifth, the baseline neonatal mortality rate in the PLA-MNH group program area. Data on these 3 is available from the PLA-MNH group context mapping matrix developed in Chapter 2. Returning to our real-world example, the program with Doctors with Africa Coam in Oyam, Uganda, this information was used to project that the PLA-MNH group program would save a total of 148 lives, 26 maternal lives and 122 neonatal lives. This projection was based on the following data: a project population of 104,500 people, a rural crude birth rate of 39.3 per thousand, a maternal mortality ratio of 500 per 100,000 live births, a neonatal mortality rate of 36 per 1,000 live births, and an implementation phase lasting 30 months. It was also based on an assumption that the PLA-MNH group program would have the maximum effect because it was delivered in line with the vast majority of the 30 PLA-MNH group planning recommendations. In particular, the PLA-MNH group program was delivered in rural areas with one group per approximately 500 people, and at least 30% of pregnant women were expected to attend meetings. So, what should you do now that you've reviewed this presentation? First, we recommend that you update the Module 2 Progress Tracker. Second, we encourage you to plan your PLA-MNH group program by doing exercise 8.1. Finally, we encourage you to finish your PLA-MNH group program plan by doing exercise 8.2. We know that watching this presentation may have raised certain questions. If so, please don't hesitate to contact us by email or phone. One of the team will be happy to help. Enjoy the course.